There he is.
Hey.
Hey, Johannes, great to see you.
Great to see you.
So Johannes and I are old friends because we were in the same core training group with a guy named Marvin Scorman, who's really one of the just great masters of ISTDP therapy. And I think so. We've been working together for a few years with Marvin. We play tapes for each other. We get a lot of intense supervision with a really neat group of people that are really good at this. And Johannes is one of the most knowledgeable people I've met in terms of just really understanding the core of this theory, and really is actually becoming a little bit of a leader in this area because his really savvy online presence. He's developed videos and instructional things, and you moderate like some of the groups on ISTDP, started a lot of things. So he's become really kind of a central figure in promoting IS, and Johannes is all in on ISTDP. Right? Everybody else talks about being integrative, and if you told me you were integrative, Johannes, I would call you a liar, because he is all in. This guy knows as much about this theory as anyone I've met. He knows all the terms. He's great at doing it. And so I was really excited that he was willing to come in and talk with us. He's got a nice, healthy private practice. Really appreciative that he's here for us.
Well, thanks for having me. That's very kind. Yeah, no, I drank the Kool-Aid. I'm really into this model. So should I just take it away? So like I mentioned earlier, I don't like the sense of talking into a black hole. So if you have thoughts or comments or concerns, just speak up. And if it becomes a conversation, so much better. If it totally derails things, we'll go back to square one. But let's try that, okay? This is an introduction to intensive short-term dynamic psychotherapy, the basics. So what are we going to do? I want to acknowledge the evidence base. We're not going to look at the evidence, but I want to at least give a courtesy nod to it, recording my work and then having someone watch it and tell me what I could have done differently. And that I've had since 2012 until now, actually, with Marvin Scorman mostly. And then I also train interns at ASU. And then I've had some peripheral training from other folks, but who cares? Let's keep it going here. All right. My hope for you is that you get a basic flavor of ISTDP. It's a very complex model, but I hope to at least impart the basics. So that's the learning objective. And then I want to talk about the basic assumptions of the model and theory in a nutshell. We're going to talk about something called the conscious therapeutic alliance. And then we'll get into contraindications. And then we'll do more of a deep dive and talk about the founder, the guy that developed it, more of the historical roots of it. And then we'll get into the key concepts, okay? And there's going to be minor examples of applications sort of sprinkled in throughout. All right. So there is an evidence base. There's over, thanks to the work of Dr. Alan Abbas, there are now over 50 studies that look at outcome data and are showing efficacy for actually a wide range of psychiatric disturbances. And a lot of them are the randomized control trial studies. So that's the gold standard, as you know. And if you want to look at those studies closer, there's a link. I can send you this PowerPoint when we're done. All right. So what are some of the basic assumptions of this model? It was, I don't know if you know who this is, but there's a doctor, his name is Gabor Mate. He's phenomenal. You should check him out if you haven't already, but he's the one that first put it this way, and I think it's put beautifully. He says, when kids are presented with a choice between attachment and authenticity or autonomy, almost invariably, the kiddo is going to choose attachment. Okay, there are some exceptions like defiance and what have you. And then defense mechanisms that once were adaptive, later in life, they tend to become maladaptive and perpetuate and drive our symptoms. So mental health disturbances. Change itself is frightening and often painful. And so most of us have some ambivalence about that because of that. And that leads us to the concept of resistance, which I'll be talking a lot more about. So resistance, when we are resisting or defending, that is what we do unconsciously to avoid experiencing psychic material that is distressing. And it's really kind of the $1,000,000 question when it comes to psychotherapy, and it goes back to Freud, is how do we deal with resistance to therapy? And we'll get into that, obviously. But from this model's point of view, change and healing comes about from making the unconscious conscious. So you can see how that has roots to Freud and psychodynamic theory. And it involves facing and working through previously avoided mixed complex emotions. A lot of times it's guilt over aggressive impulses, but not only grief, fear, joy, tender feelings, love, sexual feelings, plain old psychic hurt, like hurt feelings. All of that tends to be part of the mix of what we often sweep underneath the rug. Okay. So in order to make the unconscious conscious, it requires that we first become aware of what we do to tune it out to begin with, which are the defense mechanisms. And then we have to let them go. And so we can actually have the unconscious material come into conscious awareness. Now, as you might be able to imagine, if you start to face what you've been avoiding for a long time, you're going to be going through some things, right? And coming out the other side of that, you're going to be a changed person. So in ISTDP, we don't just talk about symptom relief, we talk about character change. So it has the potential to affect really deep change. Another assumption, it's Davenloos, the guy that founded the model, it's his interactive diagnostic roadmap using intervention response that is key, and also really to keep the work experiential. So Dr. Davenloos' model, the heart of it is that it's experiential. It's so important in order for this to work. We're also assuming that people are doing their best. Everyone is doing their best, trying to avoid pain. But the ISTDP therapist isn't neutral. It's going to help the client see ways that they're not utilizing their full potential, and actually encourage them to face what they typically customarily avoid. So that's another kind of key thing about ISTDP, is that the therapist does not pretend to be impartial. That's a big one. All right, so let's look at the theory in brief. And in a sense, this is going to be restating from a different angle what I just talked about. All right, the skinny version of it is that relational ruptures, meaning that when something goes wrong with mom and dad or whoever your caretakers are, that creates what we call attachment trauma. And that trauma, that rupture in a bond, and by the way, that rupture doesn't have to be really overt and obvious like sexual or physical abuse. It could be just that my feelings aren't taken seriously, or neglect, sort of what might seem like minor, but it really isn't. Anywho, so this gives rise to a complex set of emotions. But a lot of youth, they end up having to hide those emotions in order not to rock the boat, in order to try to preserve those relationships with the caretakers. Again, this isn't optimal, but this is unfortunately how our species, how we are, right? This tends to happen for a lot of us, if not all of us. So anyway, so then defense mechanisms are used to repress or suppress or somehow tune out from conscious awareness those emotions. Like, for better or worse, children, they don't have the ego strength to hide what they feel, right? So if a kiddo is upset, it's just going to show. But if they're in an environment where they're penalized, or the father or the mother withdraws in the face of these emotions, very quickly the kiddo is going to figure out a way not to feel them, right? Because they need their parents for survival. So those emotions get relegated to the unconscious. So the end result of this sort of mess, if you will, is that we become conflicted internally, intrapsychic conflict. So we have different motivations. Part of us wants to have our feelings and be healthy and express them so we can get our needs met. And another part of us is fearful of jeopardizing relationships. And so we're motivated to squelch and hide those emotions. The end result is that we're conflicted and neurotic, right? So anyway, like I said, this model of therapy, it involves helping the patient first see what they're doing to avoid their feelings, and then helping them let go of those defenses or turn against those avoidance strategies and face the underlying feelings instead and work through them. This process can be done with some people in a very gentle, graded way, or in a more what we call a vertical or intensive way. It really just depends on the patient and what the patient's needs are. So the mechanism of change, or the curative factor here, is resolving interpsychic conflict by facing unresolved emotions and working them through, working those out. Okay. All right. So as you can imagine, that facing what we normally customarily avoid, that sort of by definition would be distressing, right? No one's going to look forward to that, but because by definition, the reason that it got swept underneath the rug to begin with is because it's going to be painful and scary. So therefore, in order to go through that or help someone go through that, we need to have a strong conscious therapeutic alliance. Devin talked about both conscious and unconscious therapeutic alliance, and I'll get to the unconscious alliance in a minute. But let's talk a little bit about what goes into the conscious therapeutic alliance, because without this alliance, you're sort of dead in the water. It's not gonna be effective treatment, okay? So at its most basic, it involves having a consensus with the patient on what the problem is, the goal, the therapeutic task. This is essentially the definition of treatment. But also we need to really make sure that the patient feels like I'm in his or her corner. The patient should always feel heard and understood, respected, like I'm interested in really getting their priorities. They should really never feel like I'm pushing my priorities or my agenda. That's a huge no-no. So it's really partnership that we're talking about, where we and the patient are pulling in the same direction. It's really rather crucial. So it's collaborative. We're sensitive to their cultural background. We meet them where they are. If a client uses the word stress, I'm not going to say anxiety. I'm just going to use the word stress. So it's in the context of this strong rapport and this strong alliance that the more challenging and more intensive interventions can be really powerful and effective. So let's see here. Yeah, without this alliance, we get a misalliance. You know, they're going to drop out of treatment, or they're going to develop a transference neuroses. So we don't want that. All right, contraindications. And by the way, as I rattle off these contraindications, understand that the model can still be used for a lot of these conditions. You just have to adapt it. Okay. So, but for example, clients in crises, you're experiencing abuse in the home, your husband or whatever is abusing you. My priority at that point is going to be her safety. It's not going to be unlocking the unconscious and getting her in touch with all her repressed childhood memories and feelings. So think Maslow's hierarchy of needs. You don't really want to attempt an archaeological excavation in the middle of an earthquake. So it's that sort of a thing. All right, schizophrenia, although I have several schizophrenic patients and I do a graded format, but you wouldn't want to do a standard format of ISTDP with schizophrenia, but you can adapt it. You can use principles and have really good outcomes, actually. Active substance abuse, not so much. Adult antisocial behaviors, serious medical conditions, such as ulcerative colitis. Although keep in mind that if you use a very graded approach, gentle approach, this can still actually be extremely helpful. Then you have the clients whose cultural preferences include not being autonomous, but actually wish to forego their individuality for the sake of a group. That's tricky. It's hard to work with those with ISTDP. Developmental disabilities, people not voluntarily in treatment, autism, and then those that just, they're not motivated enough. Like I suggested earlier, it really takes going through some things in order to come out the other end of this kind of treatment. And there's going to be people that just want to take the edge off their symptoms. They don't actually want to get to the bottom of them and resolve them, right? So those folks, not so much.
Would you list off a few other serious medical conditions you wouldn't do this with in addition to that one?
If stress and anxiety is going to exacerbate whatever that medical condition, and if that can be life-threatening or seriously hurt you, that's your criteria.
Okay, great. Yeah, because I remember the list that Dr. Graffita provided in the beginning of class, so I'll just translate that to this one too. It sounds like it would be the same kind of ones you wouldn't want to work with.
Yeah, but like I said earlier, even like people with a psychotic process going on, you can use interpretations, you can use principles and certain aspects of the model and still have good outcomes. So it's about being creative and learning how to adapt the model. So anyway, moving right along. So here's a bit of a deep dive into more of the history and the founder. So the founder, his name is Dr. Habib Davanloo. He was Iranian born, and he's a psychiatrist. But before he became a psychiatrist, he was actually in the Iranian military. He was a colonel in their cavalry, actually. Then he was trained as a surgeon in Paris. And then at Mass General in Boston, he trained in psychoanalysis proper, took a job at McGill University in Canada, where he grew frustrated with the relative lack of efficacy with psychoanalysis proper. And, someone spending 10 years on the couch, it just didn't cut it for him. He really wanted to find a way of expediting things and having more robust results. So anywho, he developed a model rather intuitively by watching his own therapy sessions over and over. And it was more intuitive than from a deductive framework. But he always saw his model as adding to the body of knowledge of psychoanalysis. He never saw himself as creating a new model entirely, actually. Dr. David Mallon, who worked closely with Davanloo, he has been quoted as saying, Freud discovered the unconscious, Davanloo discovered how to work with it. Davanloo discovers the catalyst, right, not just for symptom relief, but character change through what he calls unlocking the unconscious. This involves a visceral experience where previously avoided feelings and impulses suddenly burst into conscious awareness. And that happens when the resistance or the defenses are sufficiently neutralized. And when you do this, when you apply the model skillfully, you're going to unlock what Davanloo called the unconscious therapeutic alliance. It sounds kind of mystical, but it's essentially what Davanloo, by that he means it's the force in all of us that is striving for health and freedom. And the way the unconscious therapeutic alliance, or the UTA, the way that it manifests is through body language. It's through spontaneous communication. Essentially what's happening is that part of the patient is directing the course of the treatment to areas that are unresolved and need to be explored and worked on. What really liberates the UTA is when the resistance goes into abeyance. Like if someone is completely guarded and defended, you're not going to have much access to the UTA usually, okay? And then Frida from Reichmann, she was a brilliant analyst. She said the patient is in need of an experience, not explanations, or not primarily explanations. And that's very much captures the heart of this model, that this is about an experience, right? You can psychoeducate someone till forever, endlessly, and not much is going to happen. So we're after an actual experience. All right, so let's get to the thing about resistance. Davanloo, he agrees with Freud that resistance is really the primary obstacle to successful treatment. And when we're talking about resistance, what we mean is the defenses, the defense mechanisms, whatever the patient is doing that makes them lose access, cut off access to all of what's inside, feelings, thoughts, impulses, okay? And part of resistance includes the patient not doing their part of the therapeutic relationship. Maybe they're sitting there passively, waiting for you to drive things, or maybe they're dominating and monologuing and talking your ear off. That would be another form of resistance. Freud's repetition compulsion is part of resistance, where you repeat old, painful, traumatic patterns over and over in your life. The patient sitting there thinking that you can magically fix them. Davanloo called that the omnipotent transference resistance. So all of this is resistance. And when individual defense mechanisms begin to form and crystallize with you, the therapist, in real time, we call that's another thing that we call resistance. So here's the thing, right? So where Freud saw resistance and felt pessimistic, he did actually, towards the end of his life, in his writings, you can see that Freud was pessimistic about the prospect of really getting through to what he called clients with superego resistance. So Freud was pessimistic about it, but Davanloo found a way to actually get through to people like that, a way of working with resistance. Here's a quote by Davenloo that I'm going to read out loud. So in the classical psychoanalytic technique, resistance is a serious impediment. In my technique, it's to be welcomed as an indicator that painful conflicts are not merely being approached, but can be brought to the surface and resolved. Each time resistance is penetrated, there is a marked and unmistakable increase in the strength of the therapeutic alliance. So Davenloo welcomes resistance. He would say things like, you don't want the patient to be sitting there and then have this battalion of tanks hidden somewhere. No, you want it all out in the open. He was an old military guy, so he would use metaphors like that. All right, a little bit about the influences, people that influenced Davenloo. Eric Lindemann, 1944, he worked with survivors of a nightclub fire. He studied PTSD, and he found that when people are in a crisis, their normal defensive maneuvers, their defenses are more fluid. And so he basically figured out that a crisis, in a sense, is an opportunity. And part of Davenloo's model is to actually induce an interpsychic crisis by heightening the tension between the part of the patient that wants to avoid things and not deal with painful things versus the part of the patient that actually wants to get better and heal. And so by intensifying that conflict, he's actually inducing the kind of crises that Lindemann discovered was very powerful. Alexander and French in 1946, they're known for short-term psychodynamic work. They would advocate for the therapist taking a very active stance, a focus on the here and now, and they coined the term the corrective emotional experience. And that's an important thing. That's where you help a patient re-experience an old conflict, but this time with you, with a different outcome, with a positive outcome instead of a negative outcome. So that facilitates what's called the corrective emotional experience. Let's see, Davenloo studied with Elvin Semrod in the 1950s. The focus was on the phenomenological, descriptive, dynamic inquiry. That's where you really want the patient to really describe frame by frame with specifics exactly what's going on and what their difficulties are. He was known for asking, how do you feel that in your body? He's been quoted as saying, investigate, investigate, investigate. So the first phase of Davenloo's model, inquiry, really draws heavily from that. You're really poring over the details of the patient's life to understand the nitty-gritty and the nuts and bolts of what's going on. All right, moving right along. All right, or let's pause for a second. Any comments, thoughts, concerns, questions?
I have a question. So this came up when you were talking about in terms of culture, some people who don't want to work on the individual part to forego that identity for the sake of the group. I'm curious and I don't know if this will be answered later, but I'm curious as to how this model has been adapted to individuals who come from a collectivist culture, where there is that focus on the we. Does this technique, is this applicable to people from that culture? And if so, how?
Yeah, it's a beautiful question. It's a great question. I would say it's a case-by-case basis. You know, you have patients from collectivist cultures, and it works for them somehow. Somehow their concerns about rocking the boat with important relationships is just not sufficiently active or activated, and somehow it still works. But if someone is really hell-bent on, I simply cannot risk upsetting my mom or my dad with individuating, right, separating, being my own person, having my own feelings, valuing my own needs. If they're terrified, if they just are not willing to take that risk, then it's really tough. I haven't figured out how to deal with that. But it's a case by case, okay? Yeah, you may just have to do supportive therapy at that point and help them with what's important to them, but somehow bypass the whole channel of helping them individuate and become their own person and have their feelings and It's really tricky. I don't think anybody has like a magic bullet for that.
Be a great topic for someone to write about, think about in more detail. Yeah, it's cool.
Yeah, definitely. So thank you for that question. Really thought-provoking. Anyone else? Any concerns, comments? No? Okay.
I have a quick question.
Yeah.
I'm just curious, when you say stress and anxiety, are you using that interchangeably? Do you think of anxiety as stress? Or is there a way to differentiate them?
Yeah, it's more nuanced in a sense, and I'll actually get to that in a minute. But essentially, in my mind, it's important to make a distinction between what Freud calls signal anxiety, which is the anxiety that we experience when threatening feelings and impulses come to our conscious mind, versus like stage fright, or you're going to a job interview or whatever, and you're nervous, or there's a car accident and you barely evade the accident. Those are different things. And so, yeah, I do think it's important to at least understand those distinctions. For purposes of psychotherapy, it's the signal anxiety that we're concerned about, because that has a crippling effect on the human psyche. We're not that concerned about, normal adaptive fear. If you see a predator or something, that's healthy.
Mm-hmm. Okay, thank you.
Sure. All right. So there's essentially three main components of ISTDP. So we'll take a step back and a closer look. There's the metapsychology, which is the overarching theory explaining what drives and resolves psychopathology. There's the psychodiagnostic assessment lens, meaning how to understand what's going on with a patient moment by moment. And then there's the technique itself, which Davenlu calls the central dynamic sequence. So let's get after it. The metapsychology, here's a picture. I call this the anatomy of the wounded psyche. The genesis is the rupture to an attachment bond. And you can see right here at the center in the circle, you see where it says bond attachment. And then the next layer, you see where it says pain of trauma to the bond. And then the cascade of emotions that follow: primitive murderous rage, sexual feelings, guilt about the rage, grief, and then the outer layer, the defenses and the resistance, the wall that people often put up as a way of, one, keeping all these feelings bottled up, and two, keeping an arm's length distance from other people. What we find in this kind of model is that the act of letting someone close to us, by close, I mean being forthcoming and transparent about what we're really thinking and feeling, somehow that act evokes all the unresolved feelings and pain from previous relational ruptures and disappointments. Okay. All right, here's another concept. Davenlu calls it the twin forces, or the dual forces in the transference. So on the one hand, we have resistance. That's the part of us that says, I've been through a lot of pain. Why on earth would I ever want to revisit that? I want nothing to do with that old pain, that heartbreak, or whatever it is. Okay. And then the other side of the patient that at some level can sense that in order to really heal, they have to face that and work through it. And those are two forces within us that kind of battle it out. And there's an inverse proportional relationship. So in a therapy session where we use ISTDP, that as complex emotions within the patient begin to rise, and then resistance slowly begins to become neutralized, the unconscious therapeutic alliance shoots up. And eventually the patient herself begins to guide the course of the treatment. But that requires that we deal with the resistance. All right, here's kind of a busy slide, but these two triangles are super important. They are what we use to guide ourselves as ISTDP clinicians. This is our compass, okay? Davenlu, he did not come up with them, but he added the impulse component. So I'll just get into it. So this right here, triangle of conflict, it's essentially, it maps out what we call intrapsychic causality, meaning that painful feelings, scary feelings, forbidden feelings are there. They begin to rise. And that triggers what Freud called signal anxiety up here, speaking of your question about anxiety and stress. It's signal anxiety. It's letting us know, there's some painful, scary, frightening feeling that is beginning to emerge that obviously was taboo in the environment in which we grew up. That anxiety is crippling. It paralyzes our functioning and our well-being. So you want to deal with that for sure. And then the patient will go unconsciously begin to utilize defenses up here in this corner, defense mechanisms that serve the function of managing the anxiety, keeping it manageable by moving further away from those emotions. So distracting yourself, eat with food or sex or whatever, anything can be used as a defense. But that's the heart of it. It's whatever we're doing to manage the anxiety by moving further away from those anxiety-provoking feelings and impulses. So that's the triangle of conflict. And then the triangle of person or triangle of others. Here, T stands for the therapist / transference, really. C are people in the patient's current life orbit, and P for the patient's past life orbit. Okay. So an example might be helpful at this point. So let's imagine, let's do a thought experiment. So we have a father who abuses his son. The son can't show his pain or his sadness or anger towards the father because it's not safe. It triggers more abuse. So those feelings have to go underground, right? So then the son manages that feat by directing the negative feelings towards himself. He ends up taking a one down position. He thinks that he's a bad person. And this is all in the service of avoiding these feelings, okay? So the defense, I am bad or inferior, it lowers the father's anxiety, which mitigates further abuse. So you can see the adaptive component, like it's actually adaptive early in life. And it also obscures the perception of the father's badness, if you will, his bad behavior at least. And then the son's emotions about it, including the anger. So, and then let's say the son grows up and he gets into one relationship after another where he takes a one down position and he ends up being treated poorly. Okay, maladaptive, right? Initially, it was adaptive for the kiddo to do this, to survive his childhood. But now, well into adulthood, when these patterns continue, not so good, right? One relationship after another where he's being abused, like who would want that on anyone, right? So if he's fortunate enough to find a good therapist, though, what the therapy can do, especially if it's ISTDP informed, is it can help him face those emotions and feelings that went underground so that he can realize that he's not bad, he's just mad and sad. And by processing those emotions, that belief of I am bad drops away. Why does it drop away? Because it served the function of repressing those emotions. So if you have those feelings, there's no longer the need for the belief. Okay, I know this is different from CBT, but this is the psychodynamic perspective. All right, Dev and Lou, this is more of the psychodiagnostic assessment lens now. So we're sort of moving away from the metapsychology to the psychodiagnostic assessment lens, although there's overlap. So Dev and Lou discovered 3 main channels of unconscious anxiety discharge. And these are really, really important to attend to in therapy. Why? Because it lets us know to what extent the patient can be challenged and confronted and engage in more intensive work versus they need a more gentle approach. So one channel of anxiety discharge is the striated or skeletal muscle tissue. So for example, if you see a patient that sighs, it means that the anxiety is being contained by striated or voluntary muscle tissue. The intercostal muscles are discharging the anxiety. If they're wringing their hands like this, okay, or they're tense, it's a sign that the skeletal muscle tissue is containing the anxiety, and it's a green light. It means that they can handle their feelings at that point. They're not going to fall apart, okay? But then there is cognitive perceptual disruption. That's when blood leaves the brain. We get so anxious that blood leaves the brain and our thoughts are jumbled or all over the place. We can't think straight. And in extreme cases, we actually black out. So when people black out, they don't remember segments of time. That's often cognitive perceptual disruption. There can be ringing in the ears or tunnel vision, that sort of a thing. Okay, I'm sure you understand that at that point, that's an anxiety that's not therapeutic. At that point, the only therapeutic task that makes sense is to regulate the anxiety. Compared to striated signaling, right? When the anxiety is in the striated muscle tissue, not so much. That's a green light. Smooth muscle tissue, there we have the gastro disturbances. Okay, that's where you have irritable bowel syndrome or nausea, queasiness. Okay, that's not so good either. Like if you were to lean on someone's defenses when they're channeling their anxiety into smooth tissue, it's just going to exacerbate that. We don't want that. So again, the idea there is to regulate the anxiety until you see a sigh or some sort of hand wringing, and then you know, okay, we're good. We can go back to leaning on defenses and looking for feelings. All right, so looking at these channels of anxiety discharge combined with the kinds of defense mechanisms that the patient is using. Are they using regressive defenses? Are they using higher order defenses? That lets us know the overall ego-adaptive capacity of the patient. And by ego-adaptive capacity, I mean the patient's ability to clearly see, recognize, and assess and respond adaptively to a situation, both internal and external. Okay. And so by getting a clear psychodiagnostic picture and the ego-adaptive capacity, that clarifies the therapeutic task. Is this someone who's sturdy, who can tolerate the de-repression of their unconscious without coming apart at the seams? Or is this someone who has some fragility and we need to be very gingerly and gentle? So, and it's a response to intervention, right? So we intervene in a certain way with the patient and then we look for what comes back at us. That's the key. But that won't work. We won't get a clear psychodiagnostic picture if we're like chit-chatting, for example, with our patients. What actually yields the diagnostic picture is pressure. Okay, so let me talk a little bit about pressure and what that means from this perspective. Here's some examples of pressure. Just out of the gate, when the therapist asks, what's the problem that brings you to therapy? That is a form of pressure, right? Because you're essentially inviting the patient to talk about painful things and reveal personal information. So even just that initial question, what brings you in for therapy, is a mild form of pressure. It's important to understand that. Therapist, can you be more specific? Can we look at a specific example of the problem? That's pressure to be specific. There's pressure there, just inherent in the question. And then you're going to see the pressure kind of ratchet up a little bit. Therapist, do you notice that you avoid my eyes when I ask about your emotions? So that's mild pressure to be self-aware of this defensive maneuver. Therapist, how did you feel towards your husband when he demeaned you that morning? So pressure to face the truth of their feelings. Therapist, how are you feeling towards me right now as I try to understand your innermost thoughts and feelings? This is pressure to be emotionally intimate or open with a therapist. So the bottom line is that pressure ratchets us up in these examples. Therapist, when you shut down in here as a way to avoid your feelings, how far can we really go together to help you with your problems? Okay, you see how the pressure is ratcheting up. This is pressure for them to see the destructive effects of their defenses. You know, cause and effect. If you remain guarded in here, how effective, how helpful is this really going to be for you? Therapist, I asked about how you feel, but you share your thoughts. You see how this creates a barrier between you and me, but more importantly, between you and your own goals. What are you going to do about that? So again, a little more pressure for the patient to be active and to turn against her defenses, to face her feelings. Or the patient is sitting there passively looking expectantly at the therapist to drive the session and come up with an answer, and the therapist remains silent. That's pressure for the patient to, one, find her own answers and to be the engine of her own therapy and not use the therapist as a crutch. So as we are intervening with our patients, the patient is going to respond either with a feeling, or at least a collaborative response, or with anxiety, or with a defense. If you remember, that's the triangle of conflict. And that lets us know where to go next. Aha, that's a feeling. Aha, that's anxiety. Aha, that's a defense. And then we know where to go. And so the diagnostic picture that's revealed through pressure, I think it deserves to be underscored. It has nothing to do with the DSM diagnoses. That is not what we're talking about when we talk about the diagnostic picture in ISTDP. We're simply talking about the patient's ego-adaptive capacity. So what are the domains of assessment? What are the things that we pay attention to with our patients that we have to assess moment by moment? Number one, the channels of anxiety discharge. I talked about them: striated, cognitive perceptual disruption, or smooth tissue, the gastro disturbances, right? The types of defense mechanisms that are used. Are they mature? Are they regressive? Are they ego-dystonic? Are they ego-syntonic? Is the patient's reality testing intact? Is there a psychotic process going on? The motivational system, how motivated are they to get to the bottom of their difficulties versus they want my help to get on disability, or they just want to take the edge off their pain by supportive therapy, or whatever it is. We're going to want to pay attention to their motivational system. And then how resistant are they? The degree or the spectrum of resistance, which means how invested are they in avoidance? Are they a little bit, medium, or high? Okay. Their self-reflective functions. Are they, to what extent are they able to reflect on their own experience? Can they differentiate their feelings from their anxiety from their defenses? To what extent are they recognizing their own role in their own difficulties? In other words, do we have an interpsychic focus or not? Is the problem other people? Like, the problem is my boss, and if only my wife stopped nagging me. Okay, the problems are externalized, right? There is no interpsychic focus. You're going to be treading water at that point. The client's ability to do their part of the therapeutic relationship. Are they sitting there passively waiting for you to talk? Are they monologuing? Okay. And then the underlying dynamic themes, the precipitating themes that stimulate emotions. It could be abandonment. It could be not being taken seriously. It could be all kinds of things, but we're going to want to pay attention to those themes that tend to trigger emotions. All right. So lastly, the technique portion of this. So Davenlu calls his technique the central dynamic sequence, and it consists of these major phases. And it's important to understand that these phases are cyclical more so than linear. And it's when the resistance, again, I've said this before, but when resistance becomes neutralized, that's when the UTA, or the unconscious alliance, really is unleashed. And at that point, you really get off the ground. Anyway, phase number one, inquiry into the presenting problems. What brings you to therapy? Depression. Can we look at a specific example of your depression so I understand how this plays out in your life? Like, I get the concept of depression, but how does it actually operate, right? So we need specifics for that. And also hopefully during this phase, we form a conscious therapeutic alliance. Remember how I said how important that is, that conscious therapeutic alliance, that the patient feel like we're in their corner, that we understand them, that we're focused on their priorities. Without that, we're dead in the water. So during this phase of inquiry, we want to form a conscious therapeutic alliance. Like this is a partnership and we're pulling in the same direction. And then the next phase is the phase of pressure. And I gave you some examples. Do you notice that you prefer to relate to the floor over me, with someone who's looking away from you? Do you notice that you're vague? These are examples of pressure. So part of ISTDP, really, the Davenlu's genius is that the therapist invites and facilitates an emotionally honest relationship. That's the whole thing here. The therapist is going to be honest with the patient about what they're doing in real time to impede their own treatment. And that kind of honesty and directness makes the work experiential. It's so powerful when it's done well. Anyway, so through pressure, then eventually there's going to be crystallization. The defenses are going to crystallize in the transference with the therapist and form like almost like a palpable wall. Okay. And then this is where we need to, the intervention of challenge comes in. Davenlu calls it the head-on collision. This is really to turn the patient against their defenses, and it also really solidifies the conscious therapeutic alliance. It's essentially pointing out reality that, look, I don't have any magic words to fix this for you, that this is on you and your efforts. And if you continue to stay distant here with me, this is going to end in failure. You just have to be honest. That's part of ISTDP. You're honest with your patients. Okay. And then this whole process, as you can imagine, it begins to mobilize really intense, complex feelings that have been unconscious, but they start to press for consciousness. And then you work through those feelings by having what Devlin calls the unlocking of the unconscious. Think of a giant zit or pimple that is getting pressure, and you squeeze that pimple until there's an eruption and all that pus comes out. Well, it's sort of like that the unconscious material comes out, okay? And then working through that, and then lastly, the consolidation phase. Davenlu calls it the analysis of the transference. That's where you really help the patient get perspective on what just happened there. Remember that quote by Frida from Reichmann earlier, where she said the patient is in need of an experience, not just explanations? Well, at this phase, the patient needs explanations to make sense of what just happened, right? So you want to give them that cognitive clarity. It's really important. Otherwise, they're just kind of left shaken and what happened here. So you really help them make sense. So here's what happened. You had these defenses. Eventually, you tore down this wall, and then these feelings came out. You see, over and over, you go around the triangle of conflict and the triangle of person. So that kind of clarity is crucial, okay? And that's the last phase of the treatment. Let's see, an important link between assessment and technique. Just that it's important to understand how different the therapeutic task is with someone who has fragility versus someone who is sturdy, okay? It's a very, very different therapeutic task. With someone who's more fragile, you're not going to go for a vertical unlocking. You're going to be gentle, you're going to be encouraging, and you're going to build capacity. You're going to help the patient at their own pace tolerate higher and higher levels of affect, okay? By definition, someone whose character structure is is organized around a borderline or psychotic level of functioning, that person is by definition fragile. And here we actually strengthen the repressive barrier. We don't try to weaken it, we strengthen it. It's important to get that. So the therapeutic task, when it comes to this graded format, it involves a couple of things, right? We're trying to build their capacity, their distress tolerance, their affect tolerance. And number one, it's a process of desensitization. Desensitization to what? Intrapsychic exposure, not like go out and face this fear in the world, but on the inside. So it's actually kind of an exposure type of model that way. And so I asked the patient how they felt towards their husband when he demeaned her that morning, and then she gets really anxious, and then I back off and I might switch the subject, or I might ask her to describe what she's feeling in her body until the anxiety is manageable again. And then I go back again, and now with the level 2. So let's see the feeling then towards your husband. And then again, back off. And then next time at level 3, a little more intensity, back off. And then at level 4, that process desensitizes the system and it builds affect tolerance, okay? And then we're also, throughout this whole process, we're replacing regressive defenses with higher order defenses. So instead of weepiness or regressing, we're going to encourage the patient to intellectualize or use humor or whatever, okay? So that's how we work with more fragile people. And then the non-fragile folks, it's called a vertical approach, the unremitting pressure and challenge. That's when you just go for a vertical unlocking and you don't let off the pressure until until the client is on the other side. Again, all of that assumes that you have a conscious therapeutic alliance, right? We're not pulling up people up a hill they don't want to go up. This all assumes that we've been given permission to work this way, that they unequivocally want to do this, that they're sick and tired of status quo. So never, ever, ever do we drag people up a hill and push something on them that they don't want to do, ever. All right, so wrapping up here, ISTDP, from my point of view, and Doug's too, obviously, it has the potential to affect character change, not just symptom relief. It can be very, very powerful. It takes a long time to learn how to get good at it. Many, many years of audiovisual training. And then my own 2 cents are that that trying to follow an intellectual roadmap or formula for treatment can really impede effective work. You don't want to let the technique itself get in the way of forming an emotional connection with your patient. That emotional connection is so important. And I see people all the time that see me for supervision or training that they're just following a script. Like, this is what I was taught, so now I'm going to do this. And they're not actually present with the patient. They're not actually tuned in. And so that's kind of a pitfall that you want to avoid. From my point of view, it's less about fidelity to the model, and it's much more about fidelity to whatever seems to help your patient, and also staying true to yourself and allowing yourself to bring in who you are and your personality into the work. This is not about becoming an ISTDP robot or anything. I see that all the time, and it's sad, actually. So the whole key is to be flexible. We don't want to be rigid about how we apply this model. And these are my references. I think that's a wrap. That's all I got for you.
Curious about, have you ever integrated any other types of either approaches or techniques, whether it's counseling related or not, with this technique? Because I'm thinking about, if a client is maybe struggling to get into their body, but you know that they're a good candidate for ISTDP, what about the use of like somatic practices like Alexander technique or something like that? Have you ever had experience with that?
Yes, and I think that's the right approach. You want to use all the knowledge that you have and bring that to bear. Whatever helps your patient is the way to go. Yeah, I do. I sometimes use solution-focused, solution-oriented techniques, mindfulness stuff. Yeah. So even though I drank the Kool-Aid, I'm about integrating whatever is going to be helpful.
Thank you.
Johannes, could you talk just for a minute? You mentioned weepiness,
Mm-hmm.
right? That's a big ISTDP term. And it's something that took a lot of reorienting for me to understand, because often therapists think of tears as breakthroughs. Oh,
Right.
the client cried. That's great. They really got in touch. But ISTDP has a much more complex understanding of the role of tears in therapy. Could you talk for just a minute about weepiness versus grief, authentic and really heartfelt grief?
Yeah. I would hope so. So it goes back to the triangle of conflict. What actually constitutes a feeling versus what's an expression of anxiety and defense. And by weepiness, we mean tearfulness, but you're treading water. It doesn't, like when you really grieve, like if you surrender to a painful feeling of grief, even the face is contorting and there's this huge wave, like it's painful, but at the end of that, you're going to be relieved, like it feels good. With weepiness, that doesn't happen. There's just this constant flat line. There's no wave-like quality like you see with an actual emotion. There's a flat line. There's just weepiness. And there's not going to be that relief where at the end of it, they're like, oh my God, that felt great. I needed to get that off my chest. So that's how you tell the difference. Weepiness doesn't come in waves, whereas an actual grief or painful emotion with tears, it's going to have a grief-like quality to it. I mean, a wave-like quality to it.
And it's, often you position it, I think, as a defense. It's a defensive posture to avoid having to go any further with things. When people get weepy, they've learned people react in a certain way. that keeps them safe. As opposed, and when I say safe, right, we're using it the way Johannes has used safe, right? Safe from having to take a deeper dive into things that are potentially more disruptive, more unsettling, more conflicted feelings towards other people. And so it's an interesting phenomenon, which is why Johannes says it takes a while to learn this really well. There's some of the simpler things that really anyone can do, as Schubner and Abbas talk about in the book. Any doctor can push on feelings a little bit and get sense. But getting into the nuances of this, boy, there's almost I've learned in myself, there's a feel to it that I can't even describe, right? I feel like this person's playing a game with me right now. I'm feeling this need to want to do so, that just takes a lot of time to develop the intuition. So that's where it gets more complicated. But weepiness is a little easier. Also, could you talk about discharge versus anger?
Yeah. So, all right, thank you. That's an important one. So if I'm encouraging a patient to feel her anger towards the husband that demeaned her, okay? But in her mind, anger means you throw things, or you yell, or you hit people. You throw it, you have a tantrum. Why would you want that? So what you have to do as an ISTDP informed clinician is you have to, first of all, help the patient differentiate actual anger, which is empowering, and it has a strength to it. It's actually calm if you really feel it, but there's a real strength to it that can help you be strong and assertive. That has to be like anger has to be detoxified. As long as anger, that the patient thinks anger is a temper tantrum or being violent, they very rightly would not want to deal with it. So that's step number one, is you have to help the patient see, I'm not asking you to have a tantrum here. This is not the same thing. So this is an inside job. Anger is something internal. And then once you feel it, your anxiety is going to come down, and then your thinking is going to be clear. And then you can bring all your resources to bear on any given situation. You'll be clear-headed. If your mind is in a hurricane and you're screaming and hollering and shouting, people think, oh, that's anger. This person is enraged. From an ISTD point of view, they're having a temper tantrum. They're not the same things. And that has to be crystal clear to the patient, or you're going to have a misalliance. They're going to think, why is this guy wanting me to have a tantrum?
Yeah, and sometimes the misunderstanding that I should just go home and punch a pillow or scream really loud, right? That the way some people have framed, kind of unlocking and letting emotions get out, they can be relieving, right? Discharge can be relieving in the short term, but it actually doesn't deal with the real problem.
Yeah, that's really well put. Yeah, it's a defense. You're discharging anxiety. It's not an actual rage when you're punching something. You're discharging tension and anxiety. If you say things like, how do you feel that on the inside? This is an inside job. Internally, what is your experience of that anger? So you want to repeat those kind of phrases over and over, that we're after something on the inside. This has nothing to do with exploding or hitting something or shouting. Not at all.
I'm just wondering, I'm thinking about IFS a lot, and I guess you could say, protocol of how to move through what the model calls protector parts, which is defenses. And so there's a way to do it. And I'm just wondering, from this model's perspective, what are some of the strategies used to deal with those defenses? Because I could imagine if you have somebody, if you want them to be more in touch with their internal experience of anger, that A, they don't know how to do that, and B, the defenses are not going to allow it for some time.
Yeah, great question. I know a little bit about IFS. So maybe the overlap with IFS and ISTDP, or at least one area, is where you want to acknowledge to the patient that their defenses has an adaptive, it used to be adaptive. That deserves to be acknowledged, that what they did to avoid their feelings actually helped them survive their childhood. So first of all, just validating that you can understand that at some point in their lives, this was probably a lifeline. You can get a lot of mileage from that. But you can say things like, so these defenses, they became your raft that got you across these rocky waters of your childhood, but you're on the shores of adulthood now. And do you see how you're still carrying the raft on your shoulders? So it's part of our job to put down this raft so you don't have to have that burden.
I love that one. That was a Marvin one, and I forgot about it. I've used it and I've lost it. I got to get back to that one. That's a beautiful one.
Right. Yes.
Yeah. Do you want to walk around the rest of your life carrying this boat on dry land? It's, you know, and you can really push them in that and say, is that way? And when they really are in line and in tune with you, they get it.
Yeah. Yeah. But that validation, that to really say, I understand this, avoiding your feelings this way, you know, with whatever means they did, that was a lifeline for you. It really helped you survive your childhood. Like, that deserves to be acknowledged. So that can soften the defense just by acknowledging that it has an adaptive, the roots are adaptive. It's no longer adaptive. Usually it's become maladaptive by the time they're an adult. So that would be one way to address it. But the other piece is that in ISTDP, we have a tremendous faith in what you and IFS might call the self, the strength of the patient's core. And we actually invite the patient to exert tremendous effort to overcome their own resistance, for the self to overcome those protector parts. So we don't just acquiesce and say, well, oh, well, here are these defenses. I guess you're a lost cause. Or no, we actually invite the patient to stand up to that side of them. So yes, this helped you survive your childhood, but look at how destructive it is now. One relationship after another on the garbage heap, failed relationships where you don't get out of the relationship what you really need and want. And then it could go that way with me too, if you stay distant with me as well. Is that okay with you? Do you really want to leave it like that? You really invite them to take a stand and say, enough, to hell with it, I'm sick of this. And then that usually ushers in all the feelings.
And do you find that once the feelings start to come up, that throughout the process, you are at the same time dealing with the defenses, because they tend to come in and out, right?
So true. That is so true. So yeah, always the defense is going to come back until you have that full-on unlocking of the unconscious, where you get a real view of the person without any defenses whatsoever. But that's like the climax. And until you're there, yeah, you're always going to be dealing with resistance or with defenses.
I borrow from IFS, Internal Family Systems, actually quite a bit. And maybe this is more in line with ISTDP, but I've related it much more to IFS. The idea of giving different parts of these folks some voice in therapy. When we hit a wall where the superego or inner critic just won't let up, I will say, let's give that side of you a place to talk. Basically, have at yourself. And I'm going to help. Let's go. If you think you're so horrible, let's give that side some space in here. And then they immediately go off on themselves, you know, in a really harsh ways. And then without me doing anything, we'll often stop and say, but I know that's not true. Okay, so let's have a dialogue with these two parts. And it can turn into like a Gestalt empty chair. But we often will label parts, not always with the IFS language, but maybe language they come up with. That it can be helpful. I found it's been helpful for me when we hit these walls.
I love that. I love that you brought that up. Thank you. I was going to talk about that, but I forgot it. Yeah, inviting so remember how I talked about the resistance side and the healthy side that wants to get better. Like, it can be so helpful to have so if the client is being really distant and guarded, to say, so there's a part of you that really takes the position that hell freezes over before you're going to let me get close to you. And would it be okay with you if we get to know that side of you a little better? Maybe that side of you deserves a voice too. Maybe that side of you deserves a seat at the table as well. And if that side of you had a voice right now, if it had word, what would that side of you feel like saying to me? And so that can be beautiful, and it can go a really long way in making the resistance conscious and ego dystonic. So that's like the main purpose of that intervention from an ISTDP point of view, to make the resistance conscious.
Yeah, because they'll say things like, "This is dangerous. Showing feelings makes me weak. You're supposed to protect yourself from other people." You know, because what I've been doing more recently, I don't know how you approach this, Johannes, but I've had them externalize the voice, at meaning that say it to yourself like you're lecturing yourself. You know, Doug, don't do this. Doug, this is scary. Doug, this puts you in a position where you will be right. And I found there's something subtle but really helpful about having them say it to themselves as an external part, as opposed to just, I can't do this. This is bad for me. This is unsafe. Because that's what these voices take them over, as if they're the only way. And when you externalize it a little bit in that way, it helps them see it as just one part that, again, has been useful, but is not useful in this situation.
Yeah. That's neat. I don't know if I've done that particular angle with it. I usually go for, if that part of you had a voice, what would it feel like saying to me? So I wanted to come, not to encourage close to cocoon of, self-directed aggression. So that part of you is feeling what towards me right now? What would it say to me if it had a voice? How does that part of you like that I'm trying to understand what you really feel and think on the inside? So if they can say, well, I guess that part of me is like, go to hell or something. All right, I'm getting mileage. They're getting closer to their actual anger.
Yeah, that's great. That's great. So this is awesome. Super helpful to us, and just a really great introductory overview of all this. And someday I'd love to have you back to talk more with the people that are really into this, because you could talk you really shine when you're getting into the intricacies of it, because he's just so knowledgeable about this and so experienced.
Yeah, well, thank you. This was fun for me. I appreciate you having me here. It was good to see you again, Doug.
Great to see you too. And I miss our groups. You guys are still going, right?
Yeah. You are also missed. We miss you.
Yeah. All right. Thanks again, Johannes, and we'll be in touch.
Take care, everyone. Bye-bye now.